higher than the national average, and as is the 65 plus. This is also showing a lower percentage of the 85 and older in the traditional all population versus just Medicaid. And this is just some of the data that comes out of the national CMS data. And then when you compare again the entire population, let's compare now, this slide does, what's the percentage of your population that's in the nursing home? And you're higher than the national average. And again, this has importance to rebalancing, to the issues we've been telling you about, that is so important, wherever you go, if you move down to a PCMH or managed care, whatever decision you make, you have got to make sure you focus on doing anything you can to keep those community-based care options available. This is, again, national data, and it shows you're an outlier compared to the United States. And then this is a gender, looking at male-female nursing home, and you can see that there's, it's close to the national indicators. And I can make this research available to anyone if you want to look at it. This is a very important slide I want you to look at. When you look at an ADL, these are daily living assistance activities of daily living. So what they do is when you look at admittance into a nursing home, the level of care, the nurse will look at and how many ADLs will depend upon whether you're nursing home eligible or not. What this data showed us, and again, this is from 2010 MDS data, so it's comparing all nursing homes. This was, I believe, Brown University report, and it showed that nursing home residents in Arkansas, general, total nursing home population, about 17% do not have really any registered ADL, which is low level of care. I remember when we were at DHS, McKinsey had done some analysis that had, in the Medicaid, about 20%, and you might have heard someone testify at some point, or the director may have talked about this at some point, or Dawn, that there's about 20% that they believe they could transition to a community setting if the supports were there. And this kind of backs up some of that, and you could see that nationally, again, there is lower level of care than the national average in some of your nursing homes. Again, I can make all this data available, but this is, again, couple years back, and I don't have the most recent MDS data, but the department could probably get that for you. And this shows the population age, and I know, Representative Farr, you weren't asking about the waivers, but I wanted to make sure you at least see the waiver ages too. Interesting, you have someone on your waiver that's 106 years of age. God bless them. 42 at age 100 or more. But this gives you a breakdown of the age in your home and community-based elder choice in your development disability waiver. Okay? If there aren't any questions, I'm going to move rapidly through this. Now, what we're going to talk about here is, again, this is the managed care versus primary care medical home or patient-centered medical home models. So we're dealing with two different models. In our recommendation, we had 3 scenarios. We're going to go through those. Nothing's different than what we had recommended, but we're going to give you a lot more information here. Again, for you all to look at. Yes.
Can I interrupt you real quickly? Senator Rice, you're recognized for a question.
Do we have this data in our packets now, what you're showing up here?
I can send that to you.
On the nursing home. And clarify for me on slide 17 where you had the national versus Arkansas, clarify, is that Medicaid only or is that all?
That's all. That's all. And what I'll do is I'll send all it's a compendium, pretty detailed analysis of many different issues too.
Mr. Chair, that, and Mr. Stephen said that was 2011, 2012. If we can get some updated, I would sure like to have it.
And I will ask, it's a good question, but I think that the nursing home MDS data that they get is very stale, and it's a few years. These reports come out, and I'll do my best to see if I can get an updated for you.
Do you feel, is there anything in that you've seen in various states in population qualifications as far as incomes that you see any difference in nursing home?
It's a good question. I want to look at that, because in there, it goes state by state, and you can actually then do a comparison on state income, average income, to figure out where you stand with other states.
If you see anything on that, I'd appreciate it. Thank you,
Yep,
Mr.
no,
Chair.
I'll make sure we get that. That's a good question.
Senator Ingram, you're recognized for a question.
John, would you also look at, we're talking about rebalancing, and so I guess if you do that, then obviously the acuity level will go up in the nursing homes.
Yes,
So,
yes.
I mean, we sort of need to know what the reimbursement rate should be, because nursing homes, long-term care are going to be taking care of a higher acuity level, so we need to see what that sort of number needs to be from surrounding areas.
So this gets to the heart of the issues of whether you go down the road of, if you take our recommendations of patient-centered medical home versus managed care. Those are issues that we said in our recommendation need to be determined, and it's based on an acuity level. So a lot of states have already paid their nursing home residents in Medicaid based on acuity. We had that when I was secretary. Richard had that in his state. That's how you pay them. So you'd have to rebase the rates. There was a discussion back in 2013 or 14 where the department started down that road with the nursing home industry here in Arkansas, and it never really culminated into anything that happened. There were a lot of discussions. So there's a lot of research that's already been done here, and absolutely that's going to be a part of, I believe, whichever way you go, rebasing on acuity has got to be a part of the decision-making. It's a great question. So when we start looking at managed care or patient-centered medical home and the comparison among the two, there's really three models that we had recommended. One would be just continue the patient-centered medical home, and the other two would be managed care, capitated, full risk. And what I want to make sure before we start here, these are just the states that have these models. And I believe a few of you have said, that word managed care, maybe that's not the right word. And I said from day one, I think it was the very first meeting we had with you all, I said, these are all care management strategies. These are dealing with how can you coordinate the care of the population. You have a traditional fee-for-service where there is no care coordination model here, really effectively coordinating the care of the patients, of the citizens that are on Medicaid. You can go down the road of patient-centered medical home where you would have a certain entity, could be a nursing home, that's going to take a certain amount of patients and say, we're going to coordinate the care of those patients. And you could do that in a patient-centered medical home like you've done already with doctors, for example, in the lower level risk. If the patient-centered medical home went into the high risk.
John, can I just interrupt for just a minute? Because one of the things, again, as a lay person,
Yes.
never heard of managed care until we started this stuff. One of the things that I've gotten more recently from what you're saying that's key, that's additive to what we've been talking about more commonly as to what is key, is not just moving toward coordinating the care, that's one element, but also this concept of risk assumption,
Yes.
where the taxpayer says, I'm not going to pay any more than X. So regardless of the coordination model, there's an element where the taxpayer of Arkansas says, this is what I'm paying, you're eating the difference.
Yes.
So as you're going through these, I want to make sure I understand that component of it, because to me, enabling the taxpayer to put that piece into the program, whatever the program looks like, is essential in order to getting anything out of it. That's one view.
And I was leading up to that, so that's, but I want to make sure as we go through it, when we talk about, and when you all talk about patient-centered medical home, PCMH, some have said in the committee, PCMH with shared savings. When you talk about PCMH, you're talking about an entity, a contractor, or it could be a nursing home, could be doctors in doctors' offices, handling a certain amount of patients, individuals, the care, before we get to the issue of risk. And it could be, we sometimes classify it as managed fee-for-service. So if you hear us say managed fee-for-service, that's like a patient-centered medical home model. They're not assuming all the risk. It's going to be certain risk. In some models, like you have today in primary care, you don't have risk with some of the primary care models you have here. There's no risk. So we wouldn't even consider that a real patient-centered medical home model that we've recommended. Because what we said from day one is, you've got to go to a model that assumes some other entity is going to bear some risk. In the managed care capitated model, which was two of our recommendations, one with the high-risk population and the other with the keeping the PCMH, but with all populations. That's going to assume that company, management company, is assuming all the risk. And that's a capitated model. It is no different than what you have with Blue Cross and Better and QualChoice. You're giving them a PMPM, per member per month payment, and if they end up having to manage that population, it costs this amount, and yet you only gave them this amount, they lose. If it's lower, they gain. So when you look at your PCMH model, what we've said in our recommendations is we like that shared savings, and we also think you ought to look at shared risk. So if you go in whatever route you go on, we would recommend you adopt those models. That's what these models are here that most of these states have. And in the states that have no risk, really, total fee-for-service, those are that's your state, and that's only a few states left. And most of them have either gone down, most into the capitated managed care route, and then some, and you can see 8 states or 9 states here, have gone to the patient-centered medical home route. Okay?
John, I've got a question. Representative Boyd, you're recognized for a question.
Mr. Stephen, I'm
Yes.
going to try to verbalize this. There are a couple questions I have regarding this full capitated managed care or capitated managed care. So one is, if we go with a per member per month like we have in the current private option, then at the end of the year, whether the insurance company made money, didn't make money, they still go back to our insurance department and negotiate pay raises again in a further year. Is that currently the way I understand it, is every year they negotiate rates, and so if they took a loss this year, well, let's go make up for it next year. Is that correct?
Yeah, I think what you're talking about is the actuarial soundness requirement. That's a CMS requirement, so the issue becomes the rate has to be actuarially sound. So yes, usually there's going to be some level of increase. But what some states have done is been able to put in the contract the shared saving to the state. So for example, we put in here a lot of stuff about Texas. What the state of Texas has come up with is a methodology to say you're only going to be allowed a certain amount of savings, and the rest of the savings would be coming back to the state. So you're not going to see it go down, Representative Boyd. So you're absolutely correct. And you're not going to see it go down in the PCMH area either. You haven't seen that in any states. The rates are continuing to go up. The question is, at what would be that growth amount? And what we said all along is CMS has indicated a 5.9% average growth in the next 10 years for Medicaid. We want you to get to somewhere where you can manage Arkansas at the lower level, 2.5 to 3%.
So when you're talking about growth, and you're talking about how it's been nationally, so as we've rolled out managed care more and more in the private market and everywhere else, how much has the cost of health care gone up compared to the average rate of inflation?
I mean, it's gone up significantly.
Exactly.
No question.
Okay, so.
And it's gone up where fee-for-service, when you used to have fee-for-service, it's went up even more. And the question is, how can you control some of it? And that's why you're bringing these different models, and now we're talking about risk. And CMS is talking a lot about any type of model they'll approve in the future, whether it's ACO or in the managed care advantage plans, they want to see some level of risk. And that's kind of where a lot of the states are going right now.
So what about models like in Florida, when we reconfigure our Medicaid, which we don't know who's going to be running DHS at the moment, so we come back, we reconfigure Medicaid, And then you have a situation in Florida where the managed care companies say, well, we thought we could do it for this, but we need another $500 million. I mean, so is our Office of Procurement sophisticated enough to go head-to-head with these large companies and really try to figure out how to contract in a way that doesn't leave Arkansas and the taxpayers holding the bag?
I mean, you've really hit on the question. I think it's like the last slide, you know. You don't have that type of sophistication today in the department. I think Director Seelig will say that to you. So there's, you know, McKinsey had recommended if you go down that road a while back, you need to bring in 20 more FTEs that are really seasoned in that area. Or if you go down the road of PCMH, they said you need to bring in 100, because now you're managing 400 contracts versus 4. So, I mean, it really depends on where you want to go. But yes, you've got to bring that expertise here, Representative Boyd, or it is not going to work either way.
So, John, so I'm looking at your chart on page 20.
Yep.
And you're saying on this chart, again, for a slow learner group like me, there's lots of acronyms here. I see 39 states that have some form of capitated risk managed care. 2/3 of those are all managed care. 1/3 of those have a hybrid. Is that correct? So
Yeah.
39 states, and Florida is one of those 39 states. And then there are lots of other ones in there.
Yeah, and Richard has indicated, because this is about a year old, looking at, I mean,
And
they
again,
change.
I'm not trying to get at, you know, is it 38 or
I think it's
37?
40. You've got North Carolina is now going to managed care, and you've got Iowa that just went, or actually did the bid, and they're still not in managed care yet. They have to be approved by CMS, but they've already gone through the whole contracting.
Okay, so a number like 39,
At least.
maybe it's plus 2 or 3.
Yes.
And then when you say PCCM, is that, we're calling that
That's
PCMH?
PCMH,
Okay.
correct.
Are those PCCM states, do they have risk associated with their programs, or are they fee-for-service, non-risk PCMH programs?
I can't say that they don't have risk, but most don't. I know some of them do not have risk. Some may have added a risk component. I don't know that answer. But I can tell you, because I know when I was in Indiana doing some review for the governor there, they had a PCMH program they abandoned because it was a $7 extra payment for docs, and they didn't see any risk, and the docs were just getting a bump in payment, and they saw it as a rate enhancement. So again, it goes to, you know, putting that all together in a...
Let me go, I just want to make sure I get the rest now here. And then there's 3 states that aren't doing either of the things, managed care in any form. So on this chart, you've got, call it 39 states that are doing some form of managed care, and then you've got 12 states or 11 states that are not doing any form of managed care, and most of those are doing PCMH. Okay.
Correct. And Alabama, again, there's caveats here because things change all the time. Alabama just recently recommended to move to some coordinated, like ACO approach. So they're doing something different. And also, Connecticut, we're going to talk about later, was a fee-for-service. They went back to fee-for-service. They had managed care. And now they have it's almost like a third-party administrative type management program, but just paying claims.
Okay, Senator Sanders, you recognize for a question.
Thank you, Mr. Chair. A couple of things. One, with respect to sort of what Representative Boyd had asked with regard to the risk of the carrier, the managed care carrier. I think there are a couple of things that we need to take into consideration, both currently in the private option. I guess we saw I guess they announced it at the last meeting where Ambetter announced that they're giving money back on the MLR. This lowers the per person average premium cost for 2014. That was the medical loss reconciliation. There's another one coming in April April that will look at 2014 called the cost sharing reconciliation. This kind of goes to the heart of, do we want to put a bronze plan on the private option? We're going to cover cost sharing for those people. The important thing to remember is, even if you look at the latest guidelines that CMS has put out for managed care, they also have that same type of arrangement in terms of the medical loss ratio. So this is, if it is not spent, it comes back. The question is, how well does the state contract with you know, with a managed care contractor. We have an 80/20 MLR currently in the exchange in the private option. We were under, I think it was around 70, 76 is what they were looking at. I mean, so this isn't one of those things where you just pay money in and you don't get it back. I think for our purposes in discussing if we were to look at managed care, particularly for the difficult populations, we would need to have a real conversation about what an appropriate MLR is, because, I mean, to Keith's point earlier about nursing homes, if you're leaving nursing homes with a higher acuity, there's more cost involved. I think looking at your case mix, what you project forward, what is a reasonable MLR? I mean, that's what the discussion is. And you're absolutely right with regard to having the ability to negotiate these contracts. I think we probably would want to have a third party helping the state negotiate these contracts. We went through the whole MMIS procurement. We had, Cognosante in place that worked on the whole process from beginning to end. Yes, we had people who were scoring and ultimately picked the vendor, but I mean, that's one of the things we have to look at. It's all in how you contract, it's all in what you do, and I think we have enough experience of sort of bad contracting to see, what we probably need to do on the good contracting front. That's all I have.
Okay. I'm going to try to go as quick as I can. So
I have
now,
one more question. Representative Ferraro, you recognized for a question.
Thank you, Mr. Chair. For what Senator Sanders says, we had an MLR of 79, but we had $7 million coming back, but we also had a 7% increase. So we really don't have a control of the increase. Okay, so tell me what the cost of managed care would be. That's kind of, I'm hearing all the numbers and the cost savings. What is managed care?
well, I'm going to get to a lot of that. I'm trying to go through it. We're going to get to that, because you have to look at, I can't tell you how much it's all going to cost right now. What we told you was, we took a baseline of what other state experience were on the savings, and we saw what they did, and they took into consideration their administrative costs. And what were the overall savings for having managed care, and what were the overall savings for having patient-centered medical home? The good thing that we did in our recommendations, we took Louisiana, which is a state on your border, which had PCMH and managed care running side by side at the same time. So we can look at that experience, and we're going to get into that later. So you can get a sense for, the savings. And what I'm trying to say in the beginning here, and I want everybody to understand this, every state's different. These are projected savings. And so I can't give you the exact amount that's going to happen, but I can tell you there are going to be administrative costs. I can tell you that there's probably somewhere around $18 million of contracts right now you have at DHS that are going to be shifted to managed care if you go to managed care. There are about $7 million redirect contract savings, and we'll get to that. But then there's going to be, if you go to PCMH, there's going to be a significant number of those contracts that stay. And then the question is, how many are duplicative, because you don't want duplication. And, so in each case, you're going to have administrative costs.
Right. Well, I guess what I'm getting at is, we had an MLR of 79, but we still had a 7% premium increase. And yes, and then if we have managed care, and we have an MLR, let's say that, then what's keep them from going and saying, okay, we want another increase?
That is a great question, because a lot of states ask that, and what you have is you have the bureaus of insurance, or whatever the individual state's composition is for that handles the private insurance plans, and they have standards that they use, including state laws that impact on how they do their redetermination of rates. For Medicaid managed care, you have to go through an approved actuarial firm. You have to submit that actuarial construction to CMS and get prior approval before the rates are set. And I think what you're going to see is that the actuarial construction in the Medicaid population is actuarially different than what you get in private insurance. And how that impacts on each individual state's rates in the private market is a much wider variability in rate increases than you'll see across state full managed care programs on a year-to-year basis. In other words, the rate of change in Medicaid managed care capitation rates is lower than what it is on an annual basis to private rates in the aggregate.
I just want to make sure that I grasp something, again, the slow learner group. So if we stay with fee-for-service, we no longer need to worry about rate increases. We can just establish a flat rate, and it'll stay flat. That's question number one. And then question number two is, if we stay with fee-for-service, then DHS will no longer have to manage contracts.
That's not correct.
Okay, all right. We've got several more questions here, so let's take through them. Senator Sanders, you're recognized for a question.
Yeah, I wanted to clarify. The MLR that was reported recently was for 2014. There was no rate increase from 2014 to 2015. In fact, there was a decrease. The rate increase that came about was for 2016. And and one could argue whether they should have been given a rate increase at all, judging from the public comments and what the carriers have said. That said, Representative Farrar, if in fact we will go back and do a medical loss reconciliation for 16, and the medical loss will equalize out if that rate was high enough or not. It's the backdoor protection. But from 14 to 15, there was not a rate increase, and that's what MLR is being currently reported. Now, the other thing, the reconciliation that will take place for 2014 is the cost-sharing reconciliation. That is, what money did the carriers have to pay out to offset cost-sharing as a result, and that's driven by utilization. So we anticipate that we're going to get money back on 2014 as well. I agree with you. I mean, the truth is, you shouldn't. I mean, if you're in Arkansas, the carriers have been experiencing something significantly different than what other states have experienced. They shouldn't be getting rate increase. I don't think they should be getting rate increases. Well, again, you'd have to ask.
Can I do this? I would appreciate it if we could. I think we've got the gist of it, and then if you guys can, it's an important topic, and I realize that, and we can do it. But if you guys can, maybe in the break, kind of get to it, and then come back, and then let me know what we need to do for the whole group, and then that way we can get at the specifics of it. And so if we can go to the next question, Representative Boyd, you're recognized for a question.
Okay, so again, this is kind of like Charlie said, for the simple-minded. So if we have a medical loss ratio of 80-20, and so we have a $7 billion Medicaid budget. So the way that math works for me is we would take that $7 billion and take 20% of it and pay it towards an administrative fee, which is $1.4 billion. So if that's not right, I need somebody to truly walk me through how that works. And if it is right, I want to know exactly where we're going to find that $1.4 billion, because as I go through all of the providers, primary care, hospitals, I can't find a single person who is really overpaid in the Medicaid system. So that leaves me to believe either we're going to have significant provider cuts when they're already underpaid for the most part in the Medicaid system, or two, we're going to start denying people chest x-rays, MRIs, and other benefits that they truly need. That's my concern, where I need some help.
I can't address what's going to happen here in the future. All I can tell you is I can share with you what has happened in states that have implemented managed care and states that implemented PCMH. And we said in our recommendations that you put in the contract, and we would recommend no rate decrease. You put it right in the contract. You can require a lot, Representative Boyd, in the contract, whether it is PCMH or managed care. Make sure that you take the contracting serious, and the legislature is involved in that discussion. So legislatively, you can do that. At the end of the day, I mean, we're going to run through a number of these states that have had good contracts and some have had bad. And in some states, the experience has been bad with managed care, and they went back into PCMH because rates have been reduced. And because individuals in the community networks were pushed out. At the end of the day, you have a problem here in your program. It is unmanaged. We know that. You've got to bring some coordinated management structure to this program, or it is going to, in our opinion, continue to grow at rates that will be unsustainable. Where are you going to get the savings? We looked at your program. We have managed state programs. There is enough money in this state, in the Medicaid program, to identify areas of overutilization, to identify areas where, again, we talked about nursing home admissions. We talked about a $27,000 community-based care average payment versus 70-some-odd thousand when you take your Halo costs. There is a lot that managed care or PCMH is going to do here to bring this cost down for the whole program. And then we said, the savings, you should be looking at reinvesting into wait list and other areas that you really need to look at, bumping up physician rates based on the Medicare cut that you've had a few years ago. So our model does not start the savings until 2017, 18, 19, in the outer years. And you'd have to manage it closely. But every state we looked at, and again, we heard from most of the state folks, that's who we went to, the leaders. At the end of the day, I did talk to some providers and others, but we were getting most of our information from the state. And when we started to look at where some of the cuts and the reductions were, we saw some issues with providers. And I can't say that that hasn't happened. And the question for you is, how do you manage it here in Arkansas and learn from all these lessons, whether you go down the road of PCMH or managed care? You have to, in our opinion, do something. And that's our feeling. So, and some of these slides will have, hopefully, answer your questions.
First of all, we have to do something. We're perfectly in alignment. The question is, do you go this route or this
Yes.
route? And one of them, it's much clearer to me on how it's paid for than the other route. So,
Understand.
thank you.
I'm hoping that this clears up, but again, there's a lot of information on different types of payment arrangements, loss ratio, and I'll make sure we follow up with you on that, so you can do your own reading on it.
All right, thank you. Representative Gray, you're recognized for a question.
Thank you. My question technically was more of as an answer to Representative Collins, who made the comment that in fee-for-service, where the provider's not going to ask for an increase. It's been 11 years since physicians have had an increase, 12 years since hospitals, and I believe 15 years since pharmacies have had an increase. So I just wanted to respond to that we haven't asked for an increase in over 10 years and are willing to continue that model with the current PCMH model. So, thank you.
All right,
And I think I would, echo that. That's why we really feel strongly that no matter what, the PCMH model Representative Gray talks about, if you do it right, we'll have savings. And the managed care model, if you do it right, we'll have savings. All of us on our team believe that. The question then is, what do you use those savings? Do you reinvest some of those savings into the program to do sort of what Representative Gray is talking about? There are other areas too. So,
And if I might, just one more time, I think what our purpose here on the task force is, and I can tell I'm a little high-strung today, I'll go take a walk, but our purpose here on the task force isn't to reinvest the savings necessarily, from what I've been told. It's to help the governor find several $200 million in savings. That was our sole purpose of this task force, and I just wanted to remind the task force of that. Thank you.
All right, thank you.
so we'll
I have a
continue on.
comment. Well,
so-
I have two more questions, I'm sorry. Senator Chesterfield, you're recognized for a question.
Yes, Madam Chair, in case I'm not here for the completion of the day, I think one of the things we've got to look at is how we align DHS differently, because it is a huge, huge department. And John's leaving, probably singing zippity-doo-dah, zippity-yay. But I would say this, it is too large. There are too many divisions. We've gotten by on the cheap paying John what we're paying him, when it should be 2 or 3 different heads of departments under DHS. And that, to me, is a form of management, how you change the division in which we find the Medicare, Medicaid piece. That should be, in my view, be a standalone division, rather than being lumped with the Division of Children and Family Services, Division of Youth Services, all of these other divisions that are ultimately so very, very important to various segments of the population. And that one person who is the head of that must manage all of that, which seems so disjointed. And so one of my suggestions is to look at how we would do management-wise if we were to take that division out of DHS and make it a standalone, since it is one of those areas where we have great growth. And so just wanted to throw that out in case I missed any of the rest of this. Thank you, and thank you, Mr. Chair.
All right, thank you. We have,
Madam Chair, sorry.
If I can just add to that, in our recommendation, we did recommend Medicaid to be a standalone, as well as the alternative, if it stays within DHS, that it have some elevation of identity and integration to do just what you said. And
So
you're
I knew
absolutely
I knew
correct.
that idea wasn't original, and I couldn't remember whether I read it in your report or whatever. But I
But
did
you're right
think it
on.
was, I did try to read that whole thing, all 50-something pages. But I do think it is worth noting and pulling out for discussion so that we can look at a more efficient way to deliver services. I think we're all of one accord on that. How we do that, whether it's patient-centered or the managed care that others are talking about, but at some point in time, DHS has got to have the authority, or a division within it, an authority to be able to give it the kind of scrutiny it needs, rather than the division head having to go to 50 different committees, deal with 50 different things within a division, and then try to do it all well. And that's another example of us trying to get things done on the cheap, because we're paying this one person to head about 5, 6 different divisions. And I think he's done a rather remarkable job myself, but it's unfair, and I don't think it's manageable. Thank you.
all right, any comments?
I'm-
All right.
I can't disagree with that.
All right. One thing that I would say before we go to another question is that we usually stop for lunch at 11:30, so I'm going to give you the option of continuing on until a certain point, and I'll let you decide when that might be.
Okay.
All right. Representative Hammer, you're recognized for a question.
Thank you, Madam Chair. One of the things I can't remember hearing said this morning or talked about this morning is we've got the discussion around controlling the cost by, reimbursement and all that. But isn't some of the cost going to be reduced by amending the state plans and changing some of the state plans? And that drives to the second point, who's going to control that discussion? Is it going to be the managed care companies that'll control that discussion, or will it be we, the legislators, that will control that discussion? And so can you speak on that as to how it would help, managed care would help drive down the cost when it comes to the state plans?
Yeah, the state plan is your DHS. They are in absolute control of the state plan. This is an executive function. They work with CMS, and they make the decisions, and it could be based on legislation. The plans have nothing to do with the state plan itself, the health plans. The health plans just comply with whatever the benefit structure is in the state plan. And you can change your state plan to meet some different type of delivery, level of care. You can do it for your assessments, but that's all DHS and legislatively driven.
So how would it play out into the future if we go managed care as far as some of the changes that could actually drive to lowering the cost that are currently in place? Would the managed care companies evaluate all that and then come back and say, okay, legislative branch, we need you to look at these areas and we need to get things changed in these particular areas, versus the department doing that now? How would that play out?
That would be really untoward. Managed care goes to their project manager, who goes to the department, and it would be the department coming to you, voicing a concern that they heard from their contractor, just like it would be today.
All right, thank you.
All right, continue
Okay,
on.
so what we're going to do here is to talk about, so the issue is, we tried to look at as many states as possible to give you an idea of what's going on out there in the world of managed care and PCMH, because this is an issue that is obviously an important one for you to determine and to review. So what you're going to find here, and what we found, and we even made calls up to this weekend again to see if things were changing, you're going to hear a lot about some states have abandoned managed care after years of managed care. Some states have now moved, most of them moved into managed care. And it keeps changing. The environment does change. So, some have had managed care for a certain number of years, the capitated model, and then all of a sudden they decide that's not best for their state. But what is absolutely clear in all of our review is that managed care capitated, full risk, the savings are more than the PCMH models out there. And that's the fact in all the states that we looked at. And so when we based our recommendations to you and looked at the modeling, we took that into consideration. So, but some have abandoned because of provider issues and some of the things that Representative Boyd has talked about. We think as a group, a lot of that can be handled in a contract, and you can learn from some of these issues that haven't gone well. I'm not going to stand up there and defend all of the managed care or PCMH. I'm giving you the facts, and so we can continue to dig on and help you make your decision. So in Oklahoma, they established what's called Sooner Care, which was a fully capitated managed care program. It started in 1995. It was initially long-term supports. It was not included, then it was added in 1999. Many of these states, you will see, go into the lower cost settings first and have started to add into the ABD environment, the higher cost settings. Shut down in 2004 after the MCOs, that's managed care organizations, requested significant rate increases. Goes to Representative Boyd's point. Recent legislation directs Oklahoma Healthcare Authority to request proposals from independent vendors for the coordination of care for the high cost. And I was speaking with the secretary in Texas last week who has complete managed care. They're probably when you say who's the state that has the longest reigning managed care, it's Texas in all populations. He was asked by Oklahoma, he told me, to go and visit with their legislative caucus to talk about managed care because they're looking at what's going on in Texas. So again, here's a state that's looking now to move to more what Texas is doing. The Connecticut program. Connecticut had 1995 to 2010 used some form of managed care for the lower income families, and it had some aspect of the ABD population, but it was the waivers, not the acute care side. Actually, the acute care, not the waivers. The waivers were in fee-for-service. In 2010, it switched back to fee-for-service. I was doing some work in 2010 in the state of Connecticut when this all happened, and there were a lot of concerns about managed care there. And the biggest concern I heard from the state that I was working with was the managed care companies weren't giving us the data we needed to determine and counter data what the population health was. We were really concerned about whether their data was accurate. There were issues about some access problems, and they decided to move away from managed care. What you will see is today they have this program where they have a third-party administrator. But the costs haven't really gone down. And you look at their costs and where they are compared to Arkansas. We tried to give you an idea. Their costs from 2010 to 14, they were at 5.9% growth per year during that time period. And then in 2014, the budget, $7 billion, and you can compare that to your budget. But in Connecticut, the full enrollee benefit is much higher than yours, much higher. And this has to do with their nursing home rates, because I know this through work we've done, are the highest in the nation. And they also have certain areas of their state where the rates are much higher than even other areas of the state. Kentucky, 2013, problems with Kentucky managed care contracting included excessive profitability, slower provider payments, complicated MCO practices for providers and beneficiaries. The decision of the Kentucky Spirit MCO to quit, that really affected the state, and that led to a lot of confusion. The state rebid the managed care system in 2014, and they picked 4 vendors, actually 5, Anthem, Coventry, Humana, Passport, and WellCare, which are operating today in Kentucky. I actually looked at the most recent dashboard, which is online, and it is very impressive in terms of the outcomes. So they've seemed to turn it around and really have some good outcomes in that state. Iowa. Currently, Iowa's going through. Iowa, similar to you, is looking at what can we do, decided to go full managed care capitated. It has created an issue. The governor there really moved somewhat in much more aggressive pace probably than some of the providers were willing to accept, and there were issues there. Remember we told you there's going to be a ramp up if you go down that road of 18 months to 2 years to do it right. Iowa primarily was staffed by contractors and few state government employees with much knowledge of managed care. But they still went forward. The RFP process has been controversial. Managed care contracts have been signed. CMS has addressed the concerns and has also talked about some of the timeframes on implementation. But there's still concerns there, and it's a very fragile environment right now. The governor and the legislature seem to, most of the legislature that we looked at seem to fully support capitated managed care, fully support it. The issue is the providers are still concerned and some of the hospitals are concerned. Question?
Yes, Representative Meeks, you're recognized for question.
Thank you, Madam Chair. Could you go, excuse me, can you go into the lawsuit apparently that's against Iowa because of the bidding process? Why is that?
Yeah. Good question.
We didn't look at detail into the lawsuit, but the basic construction, as we understand it, is that there was concerns that a state employee or employees spoke to one or more of the bidders prior to the date of submission during the bidding process. That's the major concern. On a technical level, the overarching concern, as we understand, is the transparency of the whole bidding process.
Okay, thank you. Thank you, Madam Chair.
All right, continue.
And then as of November 19th, again, right up to a few days ago, Iowa announced 42,000 providers have signed the contracts, 740 pharmacies, 2,571 physicians, 576 long-term care providers and support facilities, and 4,500 home and community-based waiver providers. The Hospital Association has filed an injunctive relief for delay, and there's a statute in there that indicates that there's an issue with the Hospital Association that they end up, they can decide on the network, and there's some issue there, and they're going through some potential litigation right now. CMS has scheduled a readiness review, and it is, I'll tell you right now, it is a messy situation right now. From my experience, it is what everything not to do if you're going to roll out managed care. And that's, again, keep going back to where you can learn from a lot of these lessons. And you have plans that have already been approved, that are already working in other states, ready to go, and they don't know what's going to happen. And so there's a lot of issues there. There was also a recent call with CMS, and CMS had a readiness call, and 500 or so providers were on the line, and it was so disruptive, CMS had to cancel the call. Again, you know, time will tell what happens here, but it hasn't got off to a good start. But again, a state that had the fee-for-service program and saw that we needed to make, or they needed to make changes, and they moved to managed care. There's a recent report that we gave to you, the Mengis Group. We saw that report came out. It's an October 2015 report. The reason why we wanted to include that is it basically went state by state. It showed you every state that has managed care, and it may even update some of the numbers that we have. It looked at all the populations. The study used an estimate of 2016 fiscal year for total Medicaid expenditures of $535 billion, and $237 billion, or 44.3%, were in capitated managed care programs. It used a mix of utilization, expected savings, no savings. Again, the report is with you. I made sure we let you see it so you can read it on your own. What you will find here, and this is what's really important if you look at the next page, these are the savings that they found. And again, it just goes to show you when we're looking at that research for you all, it's not easy to determine exactly what amount of savings there were. Some reports are different. Every report, though, does have savings for managed care capitated plans that we've seen. Some have been as low as like 1% and some as high as 20%. The one in Louisiana was 12%. At the same time, the PCMH running was somewhere around 6%. And then you look at these states, all in the Mengis report, 2016 October, you can see savings around 3.5%. Not as high as the 12% in Louisiana, But again, Louisiana's a little different because they're just starting the managed care program out. And here is why I want to make sure you understand and grasp the MENS report. If you look at every managed care program and you say, what are the savings? When they start the managed care capitated programs, the savings usually will start off very high or high, and then it begins to level off. And what you're seeing here is average savings over a significant period of time for the states that have managed care. Again, you can read that on your own. I'm going to go as quickly as I can. And I got a couple more slides, I think, and then we'll be ready to break.
Okay.
Mr. Chair, is that okay?
That's fine, go ahead.
So I want to get through Texas. So for those that, we've done some work in Texas, so we know the state pretty well. I would say Texas is one of the best examples of managed care capitated that is working. By 2020, they'll have all populations in. There's a recent report, we gave you that report, it's the Milliman study, and Texas has done a really good job in the contract with the plans. So they were the state that came out with that experience rebate type contractual arrangement where they get back a certain amount of gain share. They've really reduced these costs, and if you look at this Milliman report, which is an independent auditor, but Milliman was also asked by health plans to do this, but their name brand is very independent. And they showed the savings were significant off of the fee-for-service trend line, very significant savings over the past few years. The net savings were $3.8 billion, 7.9% total savings over that, I think it was the time period up to 2015. And then when you looked all the way to projected savings at the end of 18, they're coming in somewhere around $7 billion. The MENS study that I just showed you showed the Texas savings somewhere around $500 million a year. So again, this is significant. Why? Because you can look at some of those contracts and you can learn from that. And you could have your department here use the best of the best. And I personally have spoke to the Texas secretary and to the Medicaid director and are very willing to help your department in any way. And Richard spoke to Tennessee this weekend, and Tennessee is willing to come up here and help you as well. In fact, even testify in front of your committee if you have questions. So overall, you can look at the Milliman report. I think that report is instructive for you all. You could see the number of issues on outcomes. Dr. Ron talked about outcomes so much, and we started to look at outcomes. Texas has hospitals that actually became managed care companies, went and got a license, and were creative enough to design their own managed care, and they work alongside traditional health plans. But the outcomes are improved in Texas in all different areas, and you can see the outcomes here. So they surpassed the national performance expectation on child well-being visits, childhood immunizations. They have no interest lists at all, wait lists on community-based waiver for long-term care. They have a high level of customer satisfaction, 83%. We talked about the cost savings. The MCO Children's Health Quality Standards exceed your national averages. Asthma rates declined from 2009 to 11. Diabetes, short-term complications, the rates declined. And this is all from the Milliman report. And we can go on. There's a number of other indicators, quality standards, urinary tract infections, rates decreased nearly 20%, bacterial pneumonia decrease. All these issues result in savings in your program by keeping people as healthy as possible in their own community settings and out of ER and other high costs. And then we'll stop at Tennessee and we can start after lunch.
All right.
We're going to move into a few more states and then we'll go on to the next section.
All right, we'll have one question. Senator Elliott, you're recognized.
I was just wondering, with the exception of Texas, with all the changes that these states have gone through, to what extent did quality of care figure into their decisions to make these changes as opposed to just savings? I mean, I understand we're about savings, but I'm just not hearing very much at all about quality of care.
I'm going to hand it to Richard because he on our team specifically reviewed that issue, Representative, and it's a great question.
As you can see from Texas, they track the actual clinical outcomes. And the important thing to know is that the state doesn't pay twice for this data. This data comes through the HEDIS measures that the managed care plans are required to submit from the practitioner level up through the plan. A lot of states have taken the lead over the last 4 or 5 years on population health, and states have been implementing off of HEDIS measures additional constructions around population health orientations, including essentially with children. Most states have fairly high rates of immunization when kids are young, but some states don't. In fact, my state of Washington, interestingly enough, has a moderately low rate. That's in the managed care plans where they're incentivized to make sure that children get their immunization. In terms of multiple chronic care conditions, which is some of these conditions that you see listed, which is why we listed them here, you've heard us talk from the beginning about the importance of care coordination. So later generations, I would say over the last 3 or so years, 4 years, states have been implementing care coordination model requirements for multiple chronic care conditions that ultimately end up in the types of quality indicators of what the outcomes are through the construction of the clinical information in HEDIS, which is a federal standard of required data inputs on actual outcomes at the clinical level. So states are beginning to especially in later generation RFPs, the state of Washington just re-RFP'd the whole system 2 years ago. It's riddled in the positive sense of that, of quality standards that speak to high-cost populations, adults and children. Some states have integrated this into their foster care carve-outs. Texas just rebid their contract, and they included some quality standards that hadn't been in the prior year contract. So along with the cost savings, along with the right sizing of institutional to home and community-based care, states are becoming clinically oriented in the requirements in their MCO contracts of what they want to have measured, what they want to have for outcomes, what they're willing to incentivize, what they're willing to cost share on, and also to continue the risk on the MCO and the aggregate of the financing.
But that's where they're going, but with all of this churning of going from one kind of program to the next kind of program, I just want to be clear. Maybe I'm misinterpreting this and I'm accepting Texas. There just seems to be a real extraordinary emphasis on savings, which I get. And I'm just not seeing, and maybe I'm missing, the balance of, are we making these decisions based on extraordinary need to save at the expense of really delivering good quality care? Am I missing something here?
That's the most appropriate concern, the balance between cost savings and quality of care. I think at the first generation of managed care, which is where we hear all the horror stories from in terms of excess profitability, states didn't contract in relationship to anything but cost savings and were left somewhat unprotected. That era is long gone. There are other types of management problems that we've seen from Iowa and Kentucky, which they fixed apparently so far. I think the question that you all have is really not so much a question, it's the opportunity for both managed care and PCMH. If you go down a road for managed care, you have the opportunity to take what, as John is saying, what other states have done, integrate it into your Arkansas healthcare system knowledge that has been shared with you from Dr. Ron and others, and integrate that into a participatory aspect at some level of how you want your contracts for either managed care or PCMH constructed that are going to work for you.
Okay. All right, thanks, Madam Chair.
All right, we have one last question before we break for lunch, and it's Representative Flowers.
Well, that's a lot of pressure.
They'll be upset with you if you take too much time.
Well, I promise I won't. And I really, my question is similar to that of Senator Elliott's, and I just would piggyback and ask, I've tried to do a whole lot of listening, And the thing that I'm left with as we go to lunch, or the question is, you know, I see a lot of front end, and hear about and read a lot about a lot of front end savings as it relates to managed care. And just as Senator Elliott asked about, you know, there isn't a whole lot of talk or even policy discussion about how quality of care figures into that. And when I think back also to questions earlier regarding provider decreases, I guess my question to you is, if managed care is something that you think really, really needs to be done in order to manage the care and manage the costs and save money, how do we do that and still effectively incorporate the kinds of measures and the kinds of policies that will ensure quality of care as well as access? Because I'll pull you aside, and I do have some questions about the data regarding Texas and access, whether or not that's been affected. But how do we basically, how do we ensure that there is quality of care and incorporate into the contracts that, you know, costs to providers don't decrease, and then pay someone else to manage a system that we're already managing, and we're not in this position where Florida is, where they say, hey, we tried, but we need another $500 million.
You wanna get-
That's a great series of integrations in the question. I think that to try to construct what's going to work for Arkansas, you do need to look at what mechanisms states are using to assure quality, assure access, and assure the cost savings that are implemented into the design. There was a study done by Thomson Reuters International about 4 or 5 years ago that indicated there was between 450 billion and about 550 billion, which is $500 billion in excessive use of healthcare services in the United States. And this is when this total spend was about 1.6 billion. We're up to almost 2 trillion today. All I would say is that that's something that has been out there and has been one of the results of efficient, effective use of appropriate use of all healthcare services across a population. So this is what managed care done correctly in terms of care coordination assures. It assures that the person gets what they need, has a preventive orientation, has a crisis orientation, gets what they need at the right time, at the right place, and for the right price. There's no getting around the integration of pricing, quality, and access. So I think the recipe needs to come from the state of Arkansas of what works. Again, either in managed care or in your PCMH models, because the question of those three dynamics is the same in PCMH as it is in managed care. The methodologies are different of where you're trying to go. So I think that's critically important. And the last thing on access, that's a great question. I think from all of our experiences, there's just about no state, no matter how good it may appear, that isn't going to have an access issue for Medicaid and Medicare beneficiaries in some part of the state. Texas is pretty upfront about that, and they work with CMS, and they just have gone into the frontier area of Texas with managed care. And they have worked with CMS and providers and advocacy groups in these frontier areas. That's a legal designation under CMS. It's more rural methodologically than a rural area designation. And they're working on specialty orientations towards access. So that's something that you constantly have to work on. There got to be access issues in this state, and we've heard about some of them when we were in the Delta. But I think it's the integration of the things that you're concerned about the most. If you go down a road of managed care, or if you go down a road of PCMH, is how you construct the contractual constructions around getting what you want in your system.
Madam Chair, I have a very, very tiny follow-up.
All right.
So am I to, based upon the research that you all have done, would you say that Texas has kind of struck the best balance so far based upon the data would I look to Texas to say, okay, who has the best health outcomes, save the most money, and still controlled prices so that providers didn't suffer, and also maintain a good, strong level of access for patients?
That's really difficult, because there's Kansas, which we're going to share here with you, Tennessee. Tennessee did a really good job in the long-term care area, and Texas is obviously one that, you know, that Milliman report, and we've talked to their own state, but you would hear, if you talk to providers, you might hear different stories, so you have to really make up your own mind, because there's other issues going on too. There might be, you know, access issues in one area, but it may not be actual, it's anecdotal, and it may not be actually true, and there may be other issues, so you got to just look at the data. I would say the best states from the managed care perspective that we all looked at, that we really liked from the outcome perspective, was Texas, Tennessee, and I'm very impressed with what I'm seeing in Kansas, which I share with you here. But Kansas started off, like Iowa, in a kind of a rocky shape, especially with some of the providers. And for them to get through that and to really do a lot of quality with their DD wait list and use some of those savings the way we had recommended, I think those are the states you ought to look at.
Okay, thank you.
All right, thank you. All right, ladies and gentlemen, we're going to break for lunch. We'll see you back at 1 o'clock. Thank you very much.
Senator, everything